So I don't have any disclosures. So in terms of epidemiology of primary benign bone tumors, there's about 2,000 new cases of bone cancers a year, 6,000 of them soft tissue sarcomas, about 5 of them only involve the spine. We look at the whole primary spine tumors account for 2.5 to 8.5 per year. So benign are twice as much as malignant ones, especially in younger population. General geographic, I like to speak to a lot of the residents, tell them and the fellows that to look at where the tumor is and most likely to have the diagnosis. In terms of the anterior vertebral body, most likely it's going to be metastatic lesion, multiple myeloma, histiocytosis or chordomas. Posterior elements tend to favor aneurysmal bone cyst, osteoblastomas versus osteoblastoma. Clinical presentation usually is pain that's persistent, unrelated to activity, worse during rest or night, with spinal deformities that may be related to these benign tumors. And neurological deficit may or may not be there depending on the location or if there any pressure site effect of the tumor itself. In terms of primary bone tumors, these are just the most common ones. We'll talk briefly about each one in the next slides. So osteochondromas originate from the posterior elements most likely, and they cause spinal canal compressions and nerve root compressions. We all have to remember that removing the cartilage, if not removing the cartilage, there's a higher incidence of recurrence. Osteoblastoma is a classical tumor commonly seen in adolescent young patient. It's secondary to this tumor. Patient may develop scoliosis due to the worsening of pain. It's usually more at night, relieved by non-steroidal, more with aspirin, classical teaching. Treatment usually of osteoblastomas is based on the removal or ablation with your interventional radiologist. Osteoblastomas are pretty similar to osteoblastoma, but may manifestate differently. The most common site of osteoblastomas is the spinal column in the whole skeletal system. In contrast to osteomas, osteoblastoma can grow in the spinal canal and may cause dural sac compressions. Treatment of osteoblastomas is consistent with interlesional excision or marginal resections according to the histological grading. Aneurysmal bone cyst, and that's where it gets more interesting and more fun. Aneurysmal bone cysts are commonly seen in posterior elements of the spine in patients usually younger than 20 years old. ABCs have the tendency to involve more than one segment. Treatment of ABC consists of embolization or wide resection after embolization. ABC has an overall recurrence rate about 25%. Giant cell tumors is a commonly seen in the sacrum more than any part in the spinal column. Surgical margin should be ideally a wide resection, but because the piecemealing of a GCT has a tendency of more than 50% of recurrence, so that's why we try to get it in one piece. But sometimes these tumors are very difficult to resect, especially within the sacrum, and especially being, it's hard to convince the family members to resect these tumors, especially with knowing that this has a benign etiology. Eosinophilic granuloma is not a tumor by itself, but it tends to present like one. It's more often seen in children. Eosinophilic granuloma can cause uniform rapid flattening of vertebra, which is known, as we all know, as vertebra plana. The classical treatment, it is self-limiting, so pain control, non-steroidal, and bracing to prevent further kyphosis or deformities. So this is just a summary of the different tumors. So what are the updates? So in terms of the updates, there's a lot of role of our colleagues in interventional radiology. Selective arterial embolization by itself has been reported and is well established in multiple tumors, especially in ABCs. And new and more research has been coming out for GCT. Also ablation with thermal in osteoblastoma in the absence of any intracortical defect and with a diameter with less than more than 5 millimeter. If it's less than 5 millimeter, we should be done very carefully with precaution. The main update is mainly in the new medical treatments that's been helping us out, mainly in GCT. We've been having, so GCT has multinucleated giant cell, the hallmark of the GCT, which expresses a high level of rankles. So that's essential mediator for bone reabsorption. So suppression of these osteolytes that has been established well in literature by multiple myeloma and bone mets with the treatment of denosumab has been established. So there's trials that have been used and showed that denosumab does affect GCT. This is just a small glimpse of literature that's out there. There's a study that showed 20 patients with marked reduction in the number of giant cells up to 90%. Thomas also quoted in his paper that and evaluated the role of denosumab in patients with GCT that were unresectable. 30 over the 35 patients that they looked at had favorable tumor response within the first 6 months. Another larger study, which was done on patients with GCT, were 222 patients. 21 of these 200 were spine, had a 48% did not even need surgery, and a lot of the surgeons mentioned, and they looked at that 38% had less morbid procedure than they initially were planned for. Looking at 17 non-surgical patients, or non-operable patients treated with a median of 13 months, had a reported rate of tumor response up to 88%. So it does, all of these studies showed, it does work. But in giving denosumab, although it has been recently approved by the FDA for non-operable GCTs, we also should give calcium and vitamin D to prevent hypocalcemia. But even with giving denosumab, we have to make sure or look for the adverse reports or reports outcomes. That's been out there in the literature that it has been caused osteonecrosis of the jaw. There's also a case report that reported a patient that was given at 10 years old of age, and this patient presented later with sometimes osteoporosis. There's also a lot of concerns in the literature that the tumor may recur or even come back even worse after the stop of denosumab. So this is a case that was a case report from the Japanese literature. So this is a 41-year-old gentleman which presented with cervical spine pain and 1 month, no history of trauma. On his neurological examination was completely normal. He was worked up in terms of with terms of CT, PET, and biopsy. It turned out to be a GCT. So because of the extension of the tumor and the involvement of the vertebral artery, at that time they decided to start denosumab. His neck pain disappeared completely according to this study after administration, 3 months of administration. Due to the amazing response, they decided to continue for the next 6 months. Patient still under clinical surveillance, and they claim that he's been doing fine up to 2 years. This is just a slide to show. Initially, when he presented at the first slide shows when he initially presented, and then it shows us after 6 months, 1 year, and after 2 years. This shows you how much calcification and how much it became more and more solid. This is again a PET scan. The first one shows initially when he presented, and the last one after 2 years. This is a very nice paper that came about. It actually has a systemic review of literature that's been out there in terms of the non-surgical interventions for benign spine tumors. These are my references. Thank you.